And we go on to the first lecture by Dr. Sasko Kedev, where we know him very well in India, and he's going to talk about an imaging insight of the MeRes100 OCT follow-up at different timelines. Dr. Sasko.
Yes, thank you very much. I appreciate greatly this opportunity to share with you some of my personal insight of this great MeRes technology with OCT follow-up at different time intervals. So we all know the reason why we need a new approach for a PCI. There is still a very significant risk, ongoing risk of very late events after metallic stents, even after a few decades of initial implantation. And this new opportunity to leave nothing behind, to leave no permanent implant behind, is a really great promise. Now we have this MeRes100, which is a 100 micron sirolimus eluting BRS, which is already CE approved. So we have this very unique hybrid design. It means closed cell scaffold design on both ends with a flexible open cell in between, in the middle, which makes a great opportunity for conformability, which is very important not just for acute events, but also for a long-term outcome. We also know the advantage of these very important markers, which make this device much more visible in comparison to a first generation. So when we compare the features of the first generation BVS Absorb with the MeRes100, most important is this MeRes is thin strut 100 micron with a better crossing profile 1.2 millimeters with a significantly better visibility in terms of much more visible markers on both ends. And of course, which is also very important, it can be kept at a lab temperature cat lab. So OCT images from preclinical trials with MeRes100 was very favorable, up to 3 years, with this visible golden tube design after 3 years. And when we compare OCT images in Absorb and MeRes, there is these black holes are not so pronounced after MeRes at a long term in comparison to Absorb. I will share with you some of the insights, OCT insights from MeRes1 Extend trial, where we had 64 patients, and at 3 years we have 24 OCT follow-ups at 3 years in this patient subset, and we know this very favorable outcome of this trial that is already published. In other terms, out of 62 cases, we have only one event of ischemia-driven TLR in one patient. So there was no cardiac death, no single scaffold thrombosis in this group of patients. What is particularly important for endothelialization, more than 97% of struts were covered after 6 months. So it makes that's how we can justify and explain this favorable clinical outcome with no single case of scaffold thrombosis. Here we have one case, preliminary case from a MeRes100 with OCT follow-up at 6 months, and on the right side, on the right side, you can see one malapposed strut after procedure. And this is one of the possible explanations why this device is more forgiving in comparison to Absorb, because after 6 months, down there you can see completely covered previously malabsorbed strut. So definitely this device, this thin strut device, is more forgiving in comparison to first generation. And of course, not all BRS technologies are the same. Overexpansion is one very important feature. So even though it is recommended just to overexpand 0.5 millimeters of the initial scaffold size, we can see the structure geometry post-expansion at 3.0, 3.5 and 4.0 scaffold. And I will share with you one of the preliminary cases with MeRes100, where in a proximal LED, a scaffold of 3.5 was implanted and post-dilated with 5.0 balloon. So 3.5 dilated to 4.5 and even 5.0 non-compliant balloon at high pressure. So this is angiography. And at the 6th month, you can see complete endothelization even after significant overexpansion. So definitely another suggestion that this device is really more forgiving, more flexible device in our hands. So let's move to cases. First case I want to share with you is a young patient presented with acute coronary syndrome. So there was a significant proximal LED lesion. So it was pre-dilated, and in this case we implanted 3.5 24 millimeter MeRes, and this is a good angiographic result. There is a huge, very significant septal branch arising from the lesion. This is post-dilation, and this is the result after first post-dilation. So we did an OCT, and after this OCT you can see pretty messy situation inside the scaffold. There is a significant tissue prolapse, some thrombus present, even though struts are well opposed. So to be honest, I was not confident after this result, this acute result. So we did more aggressive post-dilation. And this is the final result. Let me focus your attention on the point where we lost our huge septal branch. So it was occluded after the procedure. So a 6-month follow-up, we can see very, very good result, very well scaffold endothelization with a thin layer of neointimal tissue, no prolapse, very clean artery. You can see very, very good endothelization. And what is also very important, at 3.5 years, septal branch was reopened. Very significant septal branch was reopened. So this is very important when we consider a long-term outcome of this technology in some bifurcational lesion. Not through bifurcations, but with some lesions at the bifurcational point. So this is OCT after 3.5 years. You can see again a very stable endothelization, fully covered, but still some dark holes are present. So this is the this run from the OCT. So we are approaching the scaffold now. So we are entering now the scaffold, and you can appreciate some black holes still present after 3.5 years, but not as strong as we used to see with absorb at the long-term follow-up, and some pretty clean golden tube segments in the scaffold. Here, let me focus your attention on the ostium of the septal branch. So this is the point when, after the procedure, septal branch was occluded, and after 3.5 years, we have a reappearance of a side branch. This is very important because most recently, there was some publication regarding the metallic, new generation metallic BRS MagmaRes from Biotronic, where they presented scaffold deformation and distal embolization with this metallic BRS after a long-term follow-up in bifurcational lesions. So this is very important point to keep our eyes on these bifurcational lesions, how they perform, not just acutely but on a long-term follow-up. And the second case I want to share with you is a 62-year-old gentleman, again presented with acute coronary syndrome. So this was a proximal LED treated with MeRes 3.5 24, and this is the result. So we ended up immediately after before diagonal branch. We did some post dilation, and this is final angiographic outcome. So at 6 months, again, we can see a very good thin layer of neo-intimal tissue covering the scaffold struts. And also on the segment where some struts were not well opposed during the initial implantation, healed pretty favorably. So this is 4-year follow-up. We have a perfect angiographic outcome at 4 years. This is the OCT. At 4 years, it's definitely much optimistic appearance of the scaffold. Now we are entering the scaffold from the last OCT run at the 4-year follow-up, and you can appreciate that there are not even those dark holes after 4 years. It's a very significant golden tube image in this vessel. So in conclusion, we can say that MeRes1 and MeRes1 Extend trial were the first human evaluation of next generation of this second generation PRS technology. And it has demonstrated high acute success and very favorable long-term clinical outcome at 3-year follow-up, with a very low MACE rate of approximately 1.8% and 0 scaffold thrombosis rate, at least in these 2 trials. OCT subset analysis demonstrated sustained meaningful area and almost complete strut coverage at 6-month follow-up, more than 97-98%. So definitely not all BRS technologies are made the same, and we should look forward to lower struct thickness BRS as one of the future technologies for PCI. However, we are looking forward for a further randomized trials and a long-term follow-up that will definitely differentiate these promising technologies. Thank you very much for your attention.
Thank you, Dr. Sasko. And can we have some comments from our moderators and chairpersons? Thank you, Ravi.
So thank you, Dr. Sasko. It was a wonderful presentation. So very interesting to see your case, where you have put a 3.5 scaffold was post-dilate to 5 millimeters. So do you think that the MeRes structure of the MeRes100 is different from Absorb, where we thought more than 0.5 millimeter will cause disruption to the scaffold? So what do you think the MeRes is, how different is from Absorb?
So definitely MeRes is a different device from Absorb, even though the material is very similar, but structure and the device is completely different from Absorb. That particular case with the 5.0 post-dilation was not performed by our center, it was another center in a trial. And at this stage, we cannot recommend routine overexpansion of these devices, but that's how we just wanted to share with you in these anecdotal cases, where you can see that even after 1.5 millimeter larger aggressive non-compliant bolus dilation, we have a favorable not just acute performance, but a long-term outcome in this technology. We definitely need some more long-term data, but our initial experience is much more favorable in comparison to Absorb, definitely.
Thank you. And also we have seen in Absorb cases where we tend to post-dilate very often. When late follow-up, we have seen aneurysms, patient that arteries becoming huge, dilatation with ectasia aneurysm, possibly related to injury due to high pressure dilatation. What have we seen in MeRes so far? Have you seen any aneurysms on follow-up?
At least in our limited experience, long-term experience, more than 4 years, we have not seen a single case with aneurysmatic remodeling. What I would like to come back again on the very important point that was raised by Dr. Colombo is recoil, potential recoil of all scaffolds. We have this evidence now even coming from MeRes, that there is not so favorable radial strength on a long term. And in bifurcational cases, they recently published the experience that scaffold is deformed and broke down with distal embolization of MeRes. We do not have such a case so far in our experience with MeRes, but we should keep an eye of a radial strength on a long-term outcome, because most of the adverse events of thrombotic complications of absorb were related to a phase where disintegration of scaffold started.
Regarding the same case, Dr. Sasko, is how feasible it is to implant a MeRes as an ostial LED lesion, because the exact location of the proximal stent strut is not visible on the MeRes. The stent is located, say, 0.1 millimeter proximal to the balloon marker. So there are high chances that when you're implanting a MeRes in an ostial LED location, you might just miss the true ostium. So, I've had difficulties in implanting a MeRes in an ostial LED lesion because you just can't make out where the stent strut is with respect to the ostial lesion. So, what is your take on implanting a MeRes in ostial locations?
Yes, you raise a very important technical aspect. I recommend that you cannot eliminate ostial LED from MeRes opportunity implantation, but you have to be sure about scaffold positioning. You have to make several different projections, find the most precise projection, and try to be to relate your scaffold with the marker's relationship on the balloon. If you're precise, you should have a good result. And you should not avoid ostial lesions with this technology.
Thank you, Dr. Sasko.